I'm Steve Kraus, UT San Antonio. First talk is basically on the Neurogenic Bladder guidelines. I'll give credit to my resident who's actually going to do an FPMRS fellowship, ERPS fellowship. Next year she helped with this as part of an article we worked on. So those are my disclosures. So this is a 10-minute brief overview on a 2 manuscript guideline with over 51 statements. We're not going to go over each one. Y'all can read that if you want, but I'll go over what's special about it and give you the gist of it. So what is special about it? Number one, we redefined it. No longer is the term neurogenic bladder really adequate. We now call it neurogenic lower urinary tract dysfunction, NLUTD. That makes sense because we're not just talking about the bladder, we're talking about the outlet and such as well. Probably the only other major issue was this is the first guideline that we've seen, including the European guidelines, that actually assessed risk and used risk stratification to help guide the guideline. So this is an example of the risk stratification from the guidelines itself. Patients who come in are either, based on the neurologic disease, they're either known to have low risk, like a stroke. They basically would have spontaneous voiding, synergistic voiding based on the neuropathology, so you shouldn't really worry about it. They may have overactivity and such, but they have low risk. Or they have unknown risk, meaning a spinal cord injury patient, I don't know what's going on in their bladder. The unknown patient, or the patient with the unknown risk, really should prompt additional workup, urodynamics, renal ultrasound, renal function studies, and such. Based on that workup, you'll come out with a table that looks like this. Again, if they have normal renal function, low PVR, they're voiding themselves fine. If you happen to get urodynamics, they would be synergistic. That would be a low-risk patient. Again, stroke is the one that comes to mind. Moderate risk, normal renal function, maybe an elevated PVR, normal ultrasound, retention, not emptying well, or overactivity with incomplete emptying, versus the high risk, again, now we've got renal ultrasound that maybe shows hydro, renal function may be elevated, urodynamics shows a hostile or concerning bladder with poor storage parameters, impaired compliance, reflux, high storage pressures. So, initial evaluation for the low-risk patient, you don't really need to do anything at all. You don't need imaging, you don't need urodynamics, you don't need anything. If they have low PVR and they're low risk, you're good to go with whatever you want to do. Cystoscopy is only indicated if the patient has an indication for the cysto, hematuria, recurrent UTI, some sort of suspected anomaly, but not just because they have low risk NLUTD. Other things that the guidelines mention, and we'll go into the other complicated issues in a minute, is autonomic dysreflexia. Again, the higher risk patients are going to have higher risk, the higher risk based on the guidelines will have higher risk for AD. So be aware, if you're doing urodynamics and a cystoscopy, the patients that are at risk for AD, you want to identify them ahead of time. And I still do the majority of these in my office. And the best thing here's a tidbit, the best thing you should be able to ask your patients is, before I do something that may prompt their AD, ask them, do they get out of their AD by themselves? When you empty your bladder, does your EAD go away? Because if it does, then you can do the same exact thing in your office. If they say no, and again, if you do enough of these, you should have pharmacologic options available to you. We have nitropaced in the office. We have nifedipine, which is off-label use for that, but it's classically been used. In my spinal cord unit, they actually, the rehab docs believe this is a response to pain, and they actually give morphine. So have it available, but most of the time, if your patients tell you, I can empty, my AD goes away, that you'll be fine doing whatever you need to do in the office. Another thing the guidelines reviewed was urinary tract infections, and we've heard a lot about UTIs today. It was really good. A lot of it aligned. Bottom line is, don't test them for asymptomatic patients. If they have no symptoms of a UTI, don't get a urine. First of all, you're not going to like what you see. Second of all, you don't need to do anything because if they're asymptomatic, you're not going to treat them anyway, which is the next one. Don't treat asymptomatic bacteria. Antibiotics should be used only if they have UTI symptoms in the presence of a UTI, not asymptomatic bacteria. Avoid daily antibiotic prophylaxis unless you truly have someone with recurrent UTIs, documented UTIs beyond a shadow of a doubt. Moving into the management options, management of patients with impaired storage, bladder storage, but they void. These are patients, again, I think about stroke patients. You can treat them the classic OAB. They're just going to have a harder to treat OAB. So antimuscarinics, beta-3s are certainly fine. You can offer them tibial nerve therapies. You can offer them sacral neuromodulation therapies. you can offer them intravesical Botox injections. Just be careful. Again, this is the one you really want to watch their PVRs. And another little tidbit is beware of the patient who says they're voiding fine, but they're really not. And then you do Botox, and then they go into retention. They're not going to blame the neurologic disease or the neurologic problem that had their baseline voiding to begin with. They're going to be blaming you because it was your Botox that pushed them over the edge. So just be aware. Make sure they're counseled properly. For those that are non-voiders, so catheter management of some kind, again, your goal here is to improve bladder storage parameters so that the kidneys are not at risk. First trials, again, antimuscarinics, beta-3s. That doesn't work. Then Botox injections. If you have a patient with high-risk bladder problems, high storage pressures, overactivity, impaired compliance, you really want to you should be getting a repeat urodynamics to confirm the improvement that you're looking for. If that doesn't work, then the advanced options, I have to say they're less often these days just because Botox does work very well, but augmentation cystoplasty for the patients who are capable and willing to do the CIC. If they're not, or if they don't have the hand function, because it's something you have to think about, urinary diversion such as some sort of conduit. Chronic catheter is always an option for the non-candidates who don't want reconstruction. For people with stress incontinence, if they're voiders, you can offer them anything you want. And again, normal voiders. So a sling, an artificial sphincter, as long as their storage parameters are acceptable. And that's an important point. If you have a patient with impaired compliance, and you may not see it on the urodynamics because one of the reasons you don't see it is they're leaking so profusely. All of a sudden you give them an outlet, and you give them outlet resistance, their pressures will now start manifesting. You'll see the high pressures. So I heard earlier there was a patient who, one of the cases, that they were afraid they wouldn't be able to get the capacity because they were leaking so bad. So in those circumstances, what we do is we do an occlusion balloon test. Some of the urodynamic catheters have balloons. The other thing you can do is you can slide another catheter alongside of it, inflate the balloon, occlude them, and you can at least get a good capacity and their storage pressures. For those who are voiding, especially for females, a mid-urethral sling is fine. If I have a patient who's doing in and out cathing, the guidelines, there's not great data because there isn't just that much good data about it, but the guideline panel really believe that a pubovaginal sling is better for those patients just because of the risk of infection. So it would be a pubovaginal sling with either autologous fascia or at least a biologic trying to avoid the mesh. In those patients, I'm often considering doing an occlusive sling where I intentionally put it too tight because they're cathing anyway, so I just make sure that I can cath in the OR. For voiders, AUS is certainly fine. For those who do CIC, and AUS is also fine, but counsel them about the risks. Make sure they're doing cathing ahead of time. The first time they learn how to do CIC is not with a fresh sphincter in them. You want them doing it ahead of time. So we will make sure they can do it ahead of time. We'll have our nurses work with them. And then, of course, what are they going to be doing post-op? So I will often put in a suprapubic tube for those patients for the first month or so until they're healed up. Okay. If they have impaired emptying, but they are truly voiding, of course, alpha blockers are an option. If they're not voiding well, then catheter management. Cleaning out, in and out cathing is always better than an indwelling catheter. Suprapubic tubes been shown to have reduced risks of infections and reduced risk of obviously outlet concerns compared to a urethral catheter. So suprapubic tube compared to a urethral catheter preferred. I put the last one with trepidation. I consider sphincterotomy. It's in the guidelines. I just hate it. But consider a sphincterotomy for male patients with NLUTDs who can facilitate emptying. Make sure they are an ideal candidate. They have to have good bladder contractions because they're going to be relying on those contractions to empty, and counsel them they have a high risk of failure. Either they're going to not empty well, or you're going to need to do something else to get them in the future. Once you've done it, use the risk guidelines. Also offer you a risk stratification to guide their follow-up. Again, low risk, you don't really need to do anything. Moderate risk, typically annual evaluation, renal function assessment, annual renal ultrasound 1 to 2 years. Urodynamics only if there's a change in their pattern. So they were dry, they were doing well, all of a sudden they start leaking again, you didn't change their therapy, a urodynamics to reassess. Or maybe recurrent UTIs all of a sudden. They've been doing fine, no UTIs, and all of a sudden they're getting UTIs, or they're getting AD again. So you want to use the urodynamics to kind of direct, or to evaluate what was causing it. Surveillance for high risk, same thing, annual exam, renal ultrasound, imaging, renal function study imaging, and then again, repeat urodynamics, at least to confirm that whatever your treatment is doing is improved your storage parameters. Once that's done, if you do Botox on them, for example, and you converted a high-pressure bladder to a low-pressure bladder, then you don't need to repeat the urodynamics every time. but you would repeat it if all of a sudden they start leaking again, or if all of a sudden they start having hydro. So in conclusion, first neurogenic NLUTD guidelines to assess the risk stratification and then personalized management based on it. It's evidence-based, and it does follow that storage and emptying concepts that we'll be talking about shortly.